with first lecture, Antimicrobial Sensitivity Testing, Report Interpretation. To deliver this talk, we have with us from Mumbai, Dr. Rahul Kamble. He is very experienced, very talented, very knowledgeable, and he has received a lot of degrees. After MD Microbiology, he is also diploma in infectious diseases. He has done PGDBA, PGDBHM, PGDCR, PGDMR, and he is also black belt in Six Sigma. Presently, he is working in, all of you know, very well-known hospital in Mumbai, Leelawati Hospital Research Center. And he has also completed a few courses from Harvard Medical School, one program from Australia, another international course in vaccinology from CMC Vellore, and he is active member of Antimicrobial Stewardship Program for the best hospitals in India. Leelawati Hospital, Asian Heart Hospital, and Hinduja Hospital. All three are top hospitals of the Mumbai. In addition, he is a JCI and NABL auditor, NABH assessor, and he helped deliver talk in a lot of forums.
A very good evening to all. Thanks, sir, for a very kind introduction. And thanks for giving me this opportunity to speak on this esteemed platform. It's indeed a pleasure speaking on the topic of my passion, that is antimicrobial susceptibility testing. So I'll be speaking on how to interpret the antimicrobial susceptibility tests. So I begin with my slides here. Before we proceed to how to interpret the antimicrobial susceptibility testing, let us understand why is it necessary to do antimicrobial susceptibility testing. In short, antimicrobial susceptibility testing help us for the selection of the right antibiotic or the right antimicrobial against that particular organism. Second, it helps us to monitor the development of resistance. For example, it helps us to monitor how much is the prevalence of multi-drug resistance resistance in a particular healthcare setting. For example, how much is the prevalence of ESBL or carbapenemase or MRSA or VRE, so that we can accordingly implement or modify our antimicrobial stewardship strategies or any interventions related to infection control in the healthcare setting. Then antimicrobial testing help us also to identify or detect new resistance mechanisms. For example, resistance mechanisms related to cholesterol or identification of resistance genes such as OXA48 or NDM or KPC or IMP, VIM, which in turn help us for a correct, accurate selection of the antimicrobial against the particular organism, especially in case of drug resistance pathogens. Then it helps the susceptibility testing help us to formulate help us to prepare an antibiogram of a particular setting, and this antibiogram can help us, the healthcare management or the infection control or the drug therapeutic team, to compare the trends of the antibiogram of a particular setting among different geographical areas and healthcare facilities. As said before, the susceptibility testing data help us to develop and evaluate preventive strategies to control and prevent and control healthcare associated infections and drug resistance. So that are the indications of susceptibility testing. That the most important prerequisite for a proper rightly done antimicrobial susceptibility testing is to have an appropriate sampling. See, the antimicrobial susceptibility tests are the drivers or the basis for implementation of the stewardship strategies. So our antimicrobial susceptibility testing should be very accurate, and for very accurate susceptibility testing, we need appropriate sampling. To quote for an example, let us see blood culture. If it is observed that most of the times blood culture, a single bottle is collected, say aerobic bottle, but as per recommendations, paired bottles should be collected from both the hands, from left hand aerobic anaerobic from one prick, and from the right hand aerobic anaerobic from another hand. Why the necessity to have paired bottles? Not all organisms are strictly aerobic. Not all organisms are strictly anaerobic. There is a large group of organisms comes under the group called as facultative anaerobes. For example, E. coli, Klebsiella, Staph, Strepto, they are facultative anaerobes. So at most of the time, they don't grow in the aerobic, or they grow very late in the aerobic bottles. Hence, I suggest for healthcare settings to add anaerobic bottle to their set of blood culture. The anaerobic bottle will pack 4 to 6 hours early than the aerobic bottle, and also the sensitivity of yielding true bacterial pathogen is more when we collect a paired bottle. So that was the importance of paired blood culture bottle. Secondly, when a blood for storage of the blood culture bottles should be done at a room temperature, it should not be refrigerated. Many times it is seen that blood culture bottles or the CSF samples are refrigerated. That should be avoided. It should be kept at a room temperature. Then extremes of temperature should be avoided for transport of samples such as blood or CSF. For any microbial sample for cultural sensitivity, say it is a sputum, pus, urine, or any other samples, the samples should ideally be processed within 2 hours of collection. If a delay is anticipated, then it can be kept at a temperature about 18 to 25 degrees Celsius. But more than that, should be avoided, or it can be kept at 2 to 8 degrees Celsius. But it should be avoided. So, if for example, say an urine sample, if you process it after some 6 to 8 hours, there are more chances of getting organisms like E. coli, which is a commensal of the urinary tract, which will overgrow a true pathogen. Say the true pathogen is Pseudomonas or Burkholder or any other Acinetobacter. This commensal will overgrow the true pathogen if we delay the processing of the microbiology samples for culture and sensitivity. Hence, as I repeat again, culture and sensitivity samples should be processed within 2 hours of collection, and the proper storage temperature should be followed. For example, blood and CSF should be kept at room temperature. If I take the example of CSF, if fastidious organisms like Neisseria meningitis or Streptococcus pneumonia or H. influenza are suspected, now better, I suggest, as per guidelines, take a warm chocolate agar plate and directly inoculate the CSF sample to the warm chocolate agar plate and send it to microbiology lab for incubation and further processing. Or else the CSF sample 1 or 2 ml can be directly inoculated into a fluid culture bottle. In the fluid culture bottle, there are antibiotic neutralizers which will favor the growth of the true pathogens. Thirdly, CSF sample, the inoculated plate should be kept in a carbon dioxide atmosphere. 5 to 10% of carbon dioxide atmosphere should be given to the inoculated culture plates to get more yield of the true pathogens. So that was about the how to do the sampling, the storage, and the transport required for the precious samples like blood and CSF. Now, as we move towards the antimicrobial susceptibility testings, there are in general two broad methods of antimicrobial susceptibility testings. One is the phenotypic method, and another is the genotypic method. We will go into details of the phenotypic method in the next few slides. And if you compare the phenotypic and the genotypic method, in the phenotypic method, it is a universally applicable method. It is mechanism independent. Means whether it is an OXA48 producer or NDM or KPC, whatever, you will get a true sensitive or resistance results in phenotypic method. It helps in exact phenotypic categorization, and it has a therapeutic relevance. However, for phenotypic method, more time is required. 18 to 24 hours is required for the bacteria to grow, and it is expression dependent. That is, even if the OXA48 or any drug resistant genes are present, if they are expressed, then only we get the results on phenotypic test. Otherwise, we don't get the test. And the advantage of the genotypic method is that we are able, in the genotypic methods, we are able to detect the particular resistance mechanism, whether it is OXA or NDM or IMP or VI. Genotypic method is a very rapid method, but again, the disadvantage of a genotypic method is that the negativity does not necessarily mean susceptibility, or the positivity does not necessarily confer phenotypic resistance. And genotypic methods are limited to particular some antibiotics only. So that was about the difference between the phenotypic method and the genotypic method. Now, which method to select depends upon the ease of performance in the lab, or the flexibility, or the resources available, or the availability of automated or semi-automated methods, or the cost, the reproducibility, the reliability, accuracy, and preference. If you see the phenotypic method, this is the most widely adopted method, and the three basic methods of phenotypic testing includes disk diffusion, broad dilution. AST provides us qualitative results in terms of sensitive, intermediate, or resistant, or AST provides quantitative results in terms of minimum inhibitory concentration. Now we will see what is the MIC in detail in the next slides. So let us see each of the phenotypic methods in detail. One of the most commonly employed method is the Kirby-Bird disk diffusion method. What happens in a Kirby-Bird disk diffusion method? We inoculate a sample into the culture plate, and from the culture plate we keep the for incubation for 18 to 24 hours, and we get the colonies of bacteria. This suspension of the bacterial colonies is made, and to another sensitivity agar plate we pour the bacterial suspension solution over the sensitive agar plate. Then we apply antibiotic discs. These are paper discs impregnated with antibiotics. Then we inoculate antibiotic discs over the culture plate wherein we had put the bacterial suspension solution. And this plates with the inoculated antibiotics and the bacterial suspension solution is incubated for 18 to 24 hours. And the next day, we then observe the clear zone around the antibiotic. We measure this clear zone around the antibiotic, and then we compare with the standard breakpoints, and we correlate with the breakpoints and then interpret at sensitive, intermediate, or resistance. If the particular zone size is more than the particular breakpoint given by guidelines, then it is sensitive. Or if it is less than the particular breakpoint given in the guidelines, then it is resistant. If it is in between, we interpret it as intermediate. So this is how Kirby-Bird disk diffusion is the antibiotic. The principle of this, the antibiotic will disperse into the culture medium and will kill the bacterial growth. And then there is a clear zone. So based on this clear zone, we determine whether the organism is either sensitive or intermediate or resistant against a particular antibiotic. If we see the MIC method, which is the recommended method as per guidelines, in this MIC method, there's a ELISA-like microvalve plates. In this microvalve plates, antibiotics are added to the microvalves in increasing concentration, and into those valves we add the bacterial suspension solution, and then we keep it for incubation for 18 to 24 hours. The next day, the valve which shows a clarity in is the MIC. The valves which shows turbidity, that means the bacterial growth is present in the antibiotic solution, so the bacteria is resistant. As we go ahead in the increasing concentration of the valves with antibiotics, the valves which show clarity is the MIC. So as you see from this picture, one is the MIC for this particular organism. MIC stands for the minimum inhibitory concentration. It is the lowest concentration of an antibiotic that prevents the turbidity, hence it is taken as the required MIC of that organism. The third method is the e-test method. In this method, a paper strip is impregnated with a particular antibiotic in increasing concentration, and in this method, in a sensitivity plate, we pour the bacterial solution, and in the after pouring the bacterial solution that is making a lawn culture, we then apply these bacterial strips. And the next day, after 18 to 24 hours of incubation, then we observe the clear zone. And the point where the clear zone gets interrupted is taken as the MIC. So e-test is another alternative if you don't have resources for a broad dilution test. So here we have seen the three methods of phenotypic testing. One is Kirby-Bird, second is a microbial dilution, and third is the e-test method. Broad dilution and e-test will give us the results in terms of quantitative results in terms of MIC, while the Kirby-Bird will give us qualitative results either sensitive, intermediate, or resistance. We have automated instruments also like Vitek instrument or Phoenix instrument. the principle of this automated methods is that it uses the broad dilution method that we discussed before. The principle is broad microdilution that is used for testing. It automatically gives a particular antibiotic solution for a particular bacterial solution, incubates it, and next day it automatically gives us the quantity results in terms of MIC, as also interprets it in correlation with the standard breakpoints. So that is the advantage of this automated instruments like Phoenix or Vitek. Another advantage is that they also have softwares like Epicenter in Phoenix or Myla in Vitek. These softwares help us to get a real-time antibiogram. Antibiogram, that is a representation of a particular sensitivity pattern of the antibiotics for different organisms in a particular healthcare setting. So we get a real-time antibiogram, department-wise, sample-wise, and organism-wise using such softwares of automated instruments. So we have seen the phenotypic method, and now comes this genotypic method. Genotypic methods include methods like PCR or DNA microarray or DNA chips or loop mediated isothermal amplification. These are some of the genotypic methods. Advantage is that it gives us, as said before, it gives a rapid identification of the drug enzymes such as KPC, IMP, VIM, or within an hour, which help the clinician to rightly select the antibiotic and on an immediate basis. So empirical therapy can be immediately started if we use such genotypic methods. To summarize, we have diffusion method, we have broad dilution method, we have e-test, and automated method, and genotypic method. The most recommended method is the MIC broad dilution method or minimum immunity concentration method, which is the gold standard of AST. If you see our antibiotics like colistin, this diffusion is not preferred for colistin. This is the MIC that is the preferred method for colistin. Because colistin is a very heavy drug, it diffuses very poorly into the culture plate. Hence, broad dilution is the preferred method. Second, now as we say, we discuss about the methods. This method gives us results either quantitatively or qualitatively in terms of MICs. Whatever the results we get, we correlate it with the breakpoints to interpret it as sensitive, intermediate, or resistance. Say for a particular organism, the breakpoint by guidelines is capital C, and if the MIC that we obtained is more than the resistant breakpoint, breakpoints can be either sensitive breakpoint or intermediate breakpoint or resistant breakpoint. If the MIC that we got using this broad dilution or the E-strip method is more than the resistant breakpoint, then it is interpreted as resistance. If it is less than the sensitive breakpoint, then it is interpreted as sensitive. If it is in between the two breakpoints, then it is interpreted as intermediate. So breakpoints are very necessary. In my setting, in my lab, we always attach the breakpoint along with the reported organism. Along with the microbiology results, I always add a breakpoint so that the clinician finds it easy to interpret whether this how sensitive the organism is or how resistant it is, and it helps them to rationally select the antibiotic. Or as the breakpoints can also be made available in the clinical stations like in ICUs or PICUs to guide the clinicians. Or it can be made available on the handheld devices like mobiles too. So let us first clear the terminologies used for AST results. One is susceptible. Susceptible means that the patient organisms should respond to the therapy with the dosage recommended normally. Resistance means the organism should not be inhibited by the recommended dosage. Intermediate means the clinical response is less likely than a susceptible state. MIC, I said before, it is the lowest concentration of the antibiotic needed for inhibit the growth of bacteria. Breakpoint, as I said before, this MIC should be correlated with the breakpoint for determining whether the sensitive susceptibility of the organisms against a particular antibiotic. Breakpoints are given by organizations like FDA or CLSI or UCAST. How these breakpoints are obtained, and we will see in the next slide. But the breakpoint, the pharmaceutical concept for breakpoints correlates with the serum achievable levels of the antimicrobial agent, depends upon the particular resistance mechanism and successful therapeutic outcome. The breakpoints are given by either by CLSI, that is Clinical and Laboratory Standard Institute, or UCAST, that is European Committee Antimicrobial Susceptibility Testing. Now, what's the difference between CLSI and UCAST? CLSI breakpoints are recognized by FDA, but FDA still has its own breakpoints, and CLSI breakpoints are reviewed every 2 yearly. the meetings of the CLSA meetings takes place every 2 yearly. It is reviewed every yearly basis, and the CLSA documents are available for sale. While UCAS, it is freely available on the website. The meetings are taken bi-yearly, and it functions as a breakpoint for European Medicines Agency. So that's the difference between CLSI and the UCAS. Most of the settings we follow CLSI, some settings find it easy to use UCAS guidelines. So where in this CLSI guidelines, we have different documents like M7, M02, M100. For example, M7 is the guidelines for aerobic bacteria, M02 is for disk diffusion. So similarly, there are many documents within the CLSI guidelines for interpretation of these testings. Now, how the breakpoints are obtained? Is done in 3 steps. One is we open for the epidemiological cutoff, that is ECOF or ECV. Then we apply pharmacokinetics and pharmacodynamics to the ECV, and then thirdly, based on clinical consideration, we obtain the breakpoints. So this is the picture of the breakpoint of a CLSI breakpoints. If you can see the MIC, this is the MIC breakpoints are different, and the zone diameters are different, and is given against for a particular organism against each of the classes of antibiotics. Say for example, for cefazolin for a particular organism, the MIC obtained by the methods we use is more than 16, and the breakpoint is about 8. That means it is a resistant. If the MIC is 1, the breakpoint is 2, it is less than 2, it is sensitive. So using these breakpoints, we interpret the particular MIC either as sensitive, intermediate, or resistant. I said before, ECOF. Let us understand what is ECOF. ECOF is what is ECOF is ECOF is the MIC, the minimum inhibitory concentration. We group into 2 groups. We divide into 2 groups. The minimum inhibitory concentration of an antibiotic for a particular organism is divided into 2 groups: wild type and non-wild type. In wild type, the MICs of a particular of a group has no resistance, no mechanisms of resistance, while in non-wild type there is known mechanisms of resistance. I repeat again, an ECV category is defined by isolates with no mechanisms of resistance. Means when we say ECOF is a wild type, means there is no mechanism of resistance. If it is a non-wild type, means there is a mechanism of resistance. So this ECV should be used when we don't have breakpoints. For example, for Shigella salmonella, we don't have breakpoints for azithromycin. In that case, we can use ECOF. For Neisseria gonorrhea, also we don't have MICs for particular antibiotics. So in that case, ECOF can be used. So ECOF should only be used when breakpoints are not available, to see whether the organism has a particular resistance mechanism, yes or no. Wild type, no. Wild type has no resistance. In non-wild type has particular resistance mechanism. That is the only significance of ECOF. So if you take this chart, ECOF value is 0.125, but the CLSI breakpoint is 1. So ECOF is much lower than the CLSI breakpoint. That means there might, though less than 1 MIC might be interpreted as sensitive, but there might be some resistance mechanism. So CLSI and ECOF can be at times be considered for selection of antibiotic. There are softwares also available for getting the ECOF when we don't have particular breakpoint for a particular organism against a particular antibiotic. We can get ECOF charting on the x-axis the zones, the MICs. For example, here in this chart, we have non-wild type in the red color, which means there is a resistance mechanism. In wild type in the blue color, which means there is no resistance mechanism. As I said, to explain more in detail about the ECOF, let us take the example of said before, Neisseria gonorrhea against azithromycin. If we get the MIC of Neisseria gonorrhea, say 4, then the ECOF for non-wild type it is more than 2. That means that particular that means it has a resistance mechanism. If for Neisseria gonorrhea the MIC is less than 1, say 0.5, and the ECOF is less than 1 for type, that means it has no resistance mechanism. So it can be considered for treatment. So based on this ECOF, when there is no breakpoint, we can take help of ECOF value when there are no breakpoint. So for example, like Neisseria gonorrhea or against azithromycin, or Shigella flexneri against azithromycin, or colistin against Klebsiella aeruginosa and other organisms. To explain another example, say Candida lucitenia. MIC that I obtained against Candida lucitenia for anidar is 2 microgram, while the ECOF is 1. Since the MIC is more than the ECOF, that means there is a resistance mechanism and could be considered non-wild type. Hence, in this case, patient should undergo clinical review, and in consultation with an ID physician or a pharmacist, the decision should be taken. Repeat again, ECOF should not be used when breakpoints have been already published. It is only a strong predictor of clinical response to therapy, but rather as an indicator of a resistance mechanism. Now, that was about the different methods of testing, phenotypic, genotypic, and the ECOF, and then about the breakpoint. Now, what does the cultural sensitivity report tell us? It tells only the identification, whether about the bacteria or the fungi. It is based on lab results. So in vivo and in vitro results might differ, the clinical results might differ, because susceptibility testing is an in vitro phenomenon and does not necessarily predict or reflect in vivo efficacy. Cultural sensitivity reports should be interpreted very carefully. It doesn't tell us about the colonization or contamination. It doesn't tell you which antibiotic to use. So the pharmacokinetics and pharmacodynamics and the clinical consistency should be taken into account. Now let us see some case example. Patient XYZ was admitted to a nursing home, was put on amoxicillin, chlorhexidine, azithromycin. However, the patient developed blood in mucus, shortness of breath, was admitted to hospital, and ET secretions yielded Klebsiella pneumonia. The sensitive pattern of the Klebsiella pneumonia was as follows. Only colistin was sensitive and Cephalosporin Ivermectin was sensitive, while other organisms were resistant like imipenem, meropenem, and cephalosporin and others. Now, which drug will you choose against this for this particular culture report? The drug now, the lab report indicated the patient is infected with Klebsiella pneumonia, is sensitive to colistin Ivermectin. Now, taking into consideration related to colistin, now colistin is a nephrotoxin. The Klebsiella is obtained from ET secretions. Colistin has a very poor penetrability in lung parenchyma. Also, for colistin, we don't have a uniform dosing for universal uniform dosing formula. So there are many issues related to colistin in ICU setting. Hence, the drug of choice will be cephalosporin Ivermectin. So this is how the PKD, and other issues related to antibiotics should be taken into consideration. Now, let's take another case study. For this Pseudomonas aeruginosa obtained from tracheal split, there might be many sensitivity and resistant antibiotics. Now, which drug to choose? For this, let us see some rules. Rule number 1, always start with a beta-lactam if possible, especially in severe infections, because they have the best data supporting their use and are generally excellent drugs, except in atypical infections. Rule number 2, do not compare the MICs between drugs. Each antibiotic has different pharmacokinetics and each antibiotic has different pharmacokinetics, that is different serum concentration, different tissue concentration. Each antibiotic has different pharmacodynamic parameters. Some antibiotics like penicillins or beta-lactams are time-dependent antibiotics. Some antibiotics like aminoglycosides are concentrate-dependent antibiotics. Some like quinolones are ASU by MIC-dependent antibiotics. So each of the antibiotics has different PKD. So do not compare the MIC between drugs. Third, if the MIC is less than equal to a breakpoint, then you can use that drug. However, exception should be noted, like if the drug doesn't get to the site of action, then even if it is sensitive, it should be avoided. If the drug doesn't achieve the goal pharmaceutical parameters, then it should be avoided. If the drug doesn't have inducible resistance, it should be avoided. Patient-specific factors, the drug cost should be taken into account. Last, microbiology always has more information than what is reported on their single piece of paper. So if further, many of the times the higher antibiotics are also not tested or not reported, or drug resistance mechanism is not tested. So the clinician or the ID physician can visit the microbiology lab or speak to the microbiologist, clinical microbiologist, and get further more data as needed for the particular case. They may have results before they are reported in the computer. Antibiotics may not be reported. They can perform additional testing. So the communication between the ID physician or the clinicians or the microbiologist is very important. Now, take another case. In Enterococcus faecalis is obtained from a blood culture. Ampicillin sensitive, dapto sensitive, penicillin sensitive, vancomycin sensitive. Which antibiotics will you choose? Now, all are sensitive. Now, then rule number 1: always start with the beta-lactam if possible. So my drug of choice will be ampicillin sensitive. Enterococcus is ampicillin. So ampicillin will be the drug of choice. Rule number 2: do not compare MIC. Other antibiotics are also sensitive. Say for example, daptomycin, but daptomycin is not better than ampicillin because the MH is lower. So ampicillin is still the drug of choice if sensitive. Rule number 3, if the less than equal to, you can use the drug with some exceptions like cost effectiveness. So other drugs are costly, so ampicillin will be more cost effective. Fourth rule, microbiology always has more information. So microbiology can also test linezolid sensitivity, which is the only oral option available against the IV options which are sensitive. But still, ampicillin will still be preferred. So drug of choice for this particular case will be ampicillin. Take another example, Klebsiella oxytocin obtained from an urine culture. Now this is the sensitivity pattern. Ampicillin is resistant. Most of the antibiotics are resistant as it is an ESBL, that is extended spectrum beta lactamase producers. That is it is resistant to third generation cephalosporin group of antibiotics. However, C4010 is sensitive. Levofloxacin is sensitive. Imipenem, meropenem is sensitive, and then tigecycline is sensitive. Now, which antibiotic will you select here? Now, for the selection, I said before, always start rule number 1. Always start with a beta lactam antibiotic. C418 was sensitive, meropenem was sensitive, but C418 will not be selected because it's an ESBL producing organism and that is resistant to cephalosporin. So C418 will be avoided. Meropenem is also sensitive, but meropenem is IV. As far as possible, we go for orally administered drugs. So meropenem will be avoided. Second, ciprofloxacin was resistant, so levofloxacin will not be used. Tigecycline was sensitive, but tigecycline had a poor urine penetration. The oxygen is obtained from urine, and tigecycline is also IV. So tigecycline will not be preferred therapy. So one treatment available is now nitrofurantoin in the given chart. So our drug of choice will be nitrofurantoin. Rule number 4, microbiology has always more information. So we can also test fosfomycin, but it can be expensive. So considering the cost effectiveness, nitrofurantoin will be the drug of choice for this particular case. So this is how the antibiotics should be selected based on for a particular considering the different factors from the culture sensitivity report. So now what should be the guidelines for therapeutic decision based on AST results? In any case, the results of AST, that is antimicrobial susceptibility testing, needs to be interpreted with some background knowledge on the biology of the organisms. So most of the organisms are intrinsically resistant or naturally resistant. For example, enterococci. Enterococci is naturally resistant to cephalosporins, aminoglycosides, salicylase, cephalosporins, aminoglycosides, salicylase, or cotrimazole. So these are the most commonly prescribed empirical therapies. So if an enterococci is obtained, it's put a huge puzzle for the clinician. So that's the natural resistance of the organism should be considered. The antibiogram should be considered before starting an empirical therapy. Do not use antimicrobials if they are not necessary. Always take into account the natural resistance. Check any unusual results. If you get at times, if it is seen that higher antibiotics are resistant and the lower first generation are sensitive and the second to third generation are resistant, so such unusual results should be retested. The patient history is important. Is underlying diseases in the previous treatment should be considered. Drug choices need to be taken into account in pharmacokinetics and the pharmacodynamics. And whenever possible, use narrow spectrum antibiotics and resort to most critically important drugs like colistin, polymyxin, and tigecycline for human use. So that was about from my presentation.
Today we are going to talk on a very commonly ordered investigation in gastroenterology as well as in general medicine, that is liver function test. Liver function test is not a single test. This is a battery of tests, some of the biochemical tests which are conducted on the patient to give and to reach at a particular diagnosis in that particular patient. Liver function test basically is a misnomer. Why? Because by just doing 5-6 tests, we cannot assess liver. Liver is a very big organ with so many functions in our body. It has been compared with just like engine of a car. Just like an engine, which is the most important part in the car, in the same way, liver functions in our body. So to assess entirely the liver function is very difficult by doing simple few of the tests. Actually, they should be called as liver chemistries. So these liver chemistries, in addition to clinical picture of the patient, as well as some of the other investigations like ultrasound, we sometimes need MRCP, we need CT scan, endoscopic ultrasound to give a proper diagnosis for the patient to reach there. Let's quickly revise the functions of liver. This is an amazing organ, more than 500 functions. It acts almost on every component in the body, which is we take orally, like fats, carbohydrates, proteins. So in carbohydrate metabolism, you can see the process of glycolysis, glycogen synthesis, gluconeogenesis, HMP shunt. Lipid metabolism, fatty acid synthesis, cholesterol synthesis, bile acid synthesis, lipoprotein. In proteins, we have urea synthesis from ammonia, plasma protein synthesis, coagulation factors, they are synthesized by liver. Amongst the hormone, we have a lot of hormones which have their metabolism in liver, like stress hormones, peptide hormones. The synthetic function, so many proteins, like all the major proteins are formed in liver, the clotting factors are formed in liver, cholesterol, triacylglycerol, lipoprotein. The excretory function, as bile pigments and bile salts are excreted in the bile by liver only. The detoxification, this is another important job done by liver, that is conversion of ammonia to urea. The drugs, so many drugs we take and they are detoxified by liver. The regulation of blood glucose level is also dependent on liver by gluconeogenesis and glycogenolysis. It acts as a very big storage organ also for glycogen, which is a very important component which maintains the glucose homeostasis in our body. The vitamin synthesis, vitamin storehouse of vitamin A, D, E, K, B12, iron. So it performs almost so many functions. So just by doing a set of biochemical tests, we cannot assess liver entirely. But still, whatever we are assessing, how they can give us a lot of information. We can assess some of the liver functions. We can assess liver damage. The biliary system can be assessed by doing liver function tests. In few of our conditions, we can monitor therapy. We can assess prognosis. For coagulation, assessment of coagulation status, hemolysis, nutritional status also can be somewhat assessed by LFT. For bony mass and bone turnover, all these functions can be assessed by these LFTs which we perform on the patient. So what are the liver function tests we order? The LFTs are the one which tells us about the hepatocellular functions. They are the enzymes. What are the enzymes? They are aminotransferases, AST or ALT. Previously, we used to call them SGOT and SGPT, but now the name has changed to aspartate aminotransferase as AST, alanine aminotransferase as ALT. Next is the alkaline phosphatase, short we write it as ALP. Then is a GGT, is gamma glutamyl transpeptidase, and lastly is a 5-nucleotidase. Although this is available, but this is only in some research labs we can get it done, not routinely. Then comes the synthetic function of liver, which can be assessed by seeing the albumin level and international normalized ratio, that is PT-INR. Then comes the bilirubin metabolism, in which we assess the serum bilirubin, which can be total, direct or indirect. So by getting all these tests, we get a lot of information. Let's come to them one by one. First is the transaminases. They are AST and ALT. The normal level previously, what we used to study in our MBBS days, that was up to from 20 to 40. That was the range given. The upper limit was 40. But now in the recent ACG guidelines, they say the upper limit has been reduced in males to from 29 to 33. And for females, this is 19 to 25. So this range is very important to take care when we assess the transaminases in the patients. These transaminases, they catalyze the reaction between keto acids and amino acids. So there is exchange of amino and keto group. ALT is more specific for liver, and AST can rise in so many other conditions also, like in liver, muscles, maybe skeleton or cardiac muscles, kidney diseases, brain diseases, or RBC related disorders. We have age, BMI, and metabolic factors. They all affect ALT level. So when we assess them, we should take care of all other parameters also. The transaminases, they have been used in the management of hepatitis B management and delay specifically, because by seeing the transaminases level, we decide upon the therapy in hepatitis B patients. Now see the transaminases, how they we assess in hepatocellular injury like alcohol. This injury can be because of alcohol, virus, drugs, autoimmune diseases, vascular injury, fatty liver, another very important condition, we call it as NASH, and congestive hepatitis. All these they cause hepatocellular injury. So we have rise in AST as well as ALT. When we have biliary injury in form of choledocholithasis, cholecystitis, cholangitis, or cholangiocarcinoma, again we have rise in AST as well as ALT. In rhabdomyolysis or muscle disorders, we have rise in rhabdomyolysis and acute MI and as well as hemolysis. We have rise of AST, but ALT remains normal. So this is a differentiating feature. By seeing the AST, ALT, if we have ALT level in thousands, we can say this is liver injury. And if we have AST level in thousands with normal ALT, that means we should look for some extrahepatic cause for the rise in transaminases. So ALT, normally we see the ALT remains more than AST in most cases of liver diseases until the patient develops cirrhosis. Once cirrhosis develops, this ratio becomes opposite. Once cirrhosis is there, AST becomes more than ALT. So this is a very important parameter. We are getting a patient of, say, chronic hepatitis B, and we are following that patient over a period of time. We see ALT is more again, and next time, after 2 years, the person comes and now this AST is becoming more. We must look for cirrhosis development in that particular patient. Another important ratio is AST-ALT ratio. If this is more than 2, then it suggests alcohol as an etiology for liver disease. So these are some of the important clues which I am highlighting. If this ratio is more than 3, then almost we should be sure that the patient, sometimes we ask the patient history of alcohol and the patient denies that history. But if we see this ratio more than 3, then we should probe or should think that the patient is denying falsely the history of alcohol. And if this ratio is more than 5, that means ALT is more than 5, that shows that something extrahepatic we must look for. Either this is rhabdomyolysis or acute MI. So some extrahepatic source of transaminases is there. This is a table which is showing the general range. Whenever we see transaminases, just wait for a minute, assess what is the range of transaminases. If transaminases are in thousands, so only 3-4 causes are there. Either this is acute viral hepatitis, or this is some drug injury. Patient is taking either ATT or some other drug which is causing hepatotoxicity. So in that case, this can increase it to thousands. Third is a very important parameter, ischemia. The patient is in admitted in cardiology, and the patient has a shock episode. The hypotension is there suddenly, and next day his LFT shows enzymes in thousands. So this is known as ischemic hepatitis. So that is another important cause. Acetaminophen overdose. The paracetamol, when patient consumes in very high doses, that can also cause transaminases to rise in thousands. So the important causes of transaminases in thousands is paracetamol poisoning, ischemic hepatitis, viral hepatitis, drug toxicity, and in pregnant patients, sometimes in Gilbert syndrome, this range can be achieved. When patient is coming with alcoholic hepatitis or steatohepatitis, this ranges to 300 to 400. Whereas in chronic viral hepatitis, again the range is in 200 to 300 and the normal remains less than 30. So by just looking the amount of transaminases, we can tell that probably this may be the cause. So the second important parameter is alkaline phosphatase. What is alkaline phosphatase? This is a collection of isoenzymes which are present in the body. They are from the family of zinc metalloproteinases. What it does, it catalyzes the hydrolysis of phosphate ester. And where all it is found? This is found in liver, canaliculi, the bone, WBCs, small intestine, placenta, and kidney. So all these are the disorders. Disorders of all these can cause rise in alkaline phosphatase. ALP is age and gender dependent. And how can we do isoenzyme fractionation? This measurement, although can be done in some of the experimental labs, but not available in routine labs. So next important test is a gamma glutamide transferases. This catalyze the transfer of gamma glutamyl group from glutamine to an amino acid, peptide or water. GGT increases in hepatobiliary diseases and it has got the same sensitivity as alkaline phosphatase. And the one important point is to remember is GGT is not found in bone. So whenever we see GGT in a patient, raised alkaline phosphatase in a patient, then to assess if the origin of that raised alkaline phosphatase is from liver or some extrahepatic source. In those cases, getting GGT done gives us a lot of information and we can tell what is the source of alkaline phosphatase. As you can see from this table, alkaline phosphatase is increased in biliary pathology, liver pathology, whenever there is high bone turnover or bone loss, bony metastasis, hyperthyroidism, long list of diseases are there, Paget's disease. And in cases of normal pregnancy also, we get this report and many a time patients are sent to us when they have raised alkaline phosphatase in pregnancy. So in those cases, this is mainly placental origin of alkaline phosphatase. How we can, the second parameter is GGT. This also increases in biliary pathology, liver pathology, but some of the diseases which are other common diseases are diabetes, patient on phenytoin or barbiturate, renal failure, pancreatic diseases, myocardial. So long list of diseases there in which GGT increases. One important point which we can see, the alcohol abuse. That is a condition in which by looking at the GGT level, we can say probably the alcohol is the etiology for liver disease. So how we can combine these two tests and tell about the origin of alkaline phosphatase? Look at the table. This shows alkaline phosphatase, gamma GT and the disease. If both are elevated, this is liver or biliary. If ALP is too much raised and GGT is also raised, this is generally seen in biliary pathology. If ALP is raised with normal gamma GT, look for any bony disease. And if exclusively gamma GT is increased, then look for alcohol as a etiology for liver disease. So by permutation and combination of these two tests only, we can tell about so many things. We always talk about raised alkaline phosphatase, but look at the low alkaline phosphatase. This is also a very important parameter. If alkaline phosphatase is low, look for hypothyroidism, look for pernicious anemia, look for zinc deficiency and a Wilson disease. This is not a very common condition, but in liver diseases, when we work up our patient, I remember a case of liver disease who came to us, young boy came to us in fulminant hepatic failure. The patient had low alkaline phosphatase. In our ward, we thought this is probably a lab error. We reconfirmed it 2 times. Every time it was coming as low. At that time, we were residents. We were not aware of this condition. And after 2 days, the patient was worked up, and it took us 2 to 3 days to work up as Wilson disease as a cause for his fulminant hepatic failure. So just by looking at single parameter, you can say the Wilson disease can be the cause for that particular liver disease problem. Now coming to the second group of tests, that is the synthetic function. Synthetic function includes, the most important is the albumin. Albumin is a protein which has got normal value of 3.5 to 5.5 grams per deciliter. It has got a long half-life of 3 weeks. This is very important. This particular fraction forms almost half of the total protein in our body. Negatively, this is negatively charged. This binds to calcium, sodium, potassium, and many hormones, even to conjugated bilirubin and some of the drugs. Why I am telling this is important, that this is like, we know that I will tell you this fact later on. This maintains the capillary oncotic pressure. The decrease in albumin indicates, just by looking at albumin of a patient, if this is low, we can make out that this particular person has a disease more than 3 weeks, because half-life of albumin is 3 weeks. And any chronic illness, irrespective of liver involvement, can cause low serum albumin. The binding of albumin to some of the drugs is very, very important. Why? Because say the patient is taking anti-tubercular therapy and the patient has low albumin. So in that case, the bind fraction and the unbind fraction, that will change, and sometimes the patient can develop toxicity. We have seen the patients who have low serum albumin, they have more hepatotoxicity due to anti-tubercular therapy. So by correcting the albumin level, whatever the way, by giving good nutrition or by IV albumin, we can prevent some of the liver injuries by correcting the albumin level. We talk about generally low albumin, but now there is another important parameter which is known as protein gap or gamma gap. What is that? When we subtract albumin from total protein, normally this value should be less than 4. So if this value is more than 4, what all we should suspect? Because if this fraction is more, that means the person is having more of gamma globulin. So what are the causes of raised gamma globulin? In our liver disease patient, we think of autoimmune as a pathology of liver disease. Patient can have multiple myeloma. In hepatitis C also, we have hypergammaglobulinemia. HIV also. Sepsis, another important cause. So just by looking at raised gamma gap, look at so many conditions we can suspect. And we should further do investigation to confirm them. Albumin is decreased in either we have decreased synthesis, like in chronic liver disease or malnutrition, or where we have increased loss. The loss can be from kidney in the form of nephrotic syndrome, or patient may have protein losing enteropathy. So this can cause increased loss of albumin. Thirdly, sometimes patient have internal redistribution, like in DIC. This capillary permeability is changed. So internal redistribution of albumin causes low serum albumin. This should be kept in mind. AG reversal, a very, very important parameter in patients of liver disease. Whenever we are following them, like chronic hepatitis or alcoholic liver disease, whenever we start seeing albumin globulin ratio reversal, must look for chronic liver disease. A single parameter gives lot of clue to investigate further. Next comes the next synthetic function is PT or INR. PT INR is based on prothrombin time. Prothrombin time, this depends on the extrinsic clotting factors, pathways, and this is far more sensitive than albumin, especially in acute liver failure. Why? Because half-life of albumin is 3 weeks. So in acute liver failure, for albumin to come down and to be assessed as a synthetic function of liver will be too early. But by just looking at PT-INR, we can come to know there is acute liver injury. So PT may increase in severe liver disease, and it has been seen that PT measurement varies significantly between different labs. To correct this anomaly, the INR is calculated. This is basically a calculation which can correct the inter-lab variation of prothrombin time measurement. INR is increased, which suggests that the synthesis of clotting factors is impaired. So what are the conditions in which we see? One is a chronic liver disease, acute liver failure, vitamin K deficiency. Why in vitamin K deficiency? Because we have studied in our basic classes that clotting factors 2, 7, 9 and 10, they are vitamin K dependent. And what are the conditions in which we get vitamin K deficiency? The one is a malnutrition. The second is fat malabsorption, because this is a fat dependent absorption, vitamin K. Thirdly, the use of broad spectrum antibiotics, which is very commonly done. And what happens, these antibiotics, they kill the normal gut flora, which is responsible for production of vitamin K. Then lastly, patient who is on anticoagulant therapy like warfarin, coumarin, decamerol. So all these, they can cause raised PT-INR. Increased consumption of clotting factor like in DIC, and rarely in hypothermia also, patient can have raised INR. So by looking at INR, we must look for in our mind, okay, these are the conditions in which this can be increased. Lastly is the bilirubin. Bilirubin, what is bilirubin? Just revising our basic physiology. This, how it comes from the senescent RBCs. Once they are hemolyzed, then heme is produced. Heme produces biliverdin. Biliverdin gets converted into unconjugated bilirubin. If we measure this fraction, this is known as indirect bilirubin. This process occurs in macrophages. The RBCs, breakdown of which forms the hemoglobin. Hemoglobin gets converted into biliverdin in macrophages. From macrophages, this unconjugated bilirubin is transported to liver. So in liver, what happens? The glucuronic acid gets attached to this unconjugated bilirubin to form conjugated bilirubin. Why this conjugation is required? Because this unconjugated bilirubin is water insoluble. So that cannot be secreted in the bile. By doing conjugation, by getting it conjugated, this gets secreted in the bile. Once it reaches the intestine, then colonic bacteria, they act on it, and that converts it into urobilinogen or stercobilinogen. This urobilinogen is excreted in urine, and stercobilinogen is excreted in stool. An important point here to mention is a fraction of this conjugated bilirubin gets attached to albumin, which is known as delta bilirubin. What is the clinical significance of this delta bilirubin? This is a fraction which is responsible for delay in resolution of jaundice. Sometimes what happens, patient comes to us with viral hepatitis or say obstructive jaundice. We have removed the obstruction, but the bilirubin comes down very slowly after 2-3 weeks. A patient relatives, they come to us that you have removed the obstruction, you have put the stent, but bilirubin is not coming down. Why? This is because of this fraction only, because half-life of albumin is 3 weeks. So the delta fraction will continue to show the raised serum bilirubin, even though the patient has recovered from the obstruction. So increase in serum bilirubin, the serum bilirubin has got a very important role in LFTs, because this increases in either hepatocellular injury or in biliary tree injury. Why? But just again look at this picture. Bilirubin can increase either the hemoglobin breakdown is more and more of bilirubin is formed, unconjugated bilirubin is formed, or some liver disease is there. So this conjugation pathway is problematic, or there is some obstruction in the biliary tree. So the excretion pathway is more. So in this case, when hemolysis is more of unconjugated bilirubin will be high. If this conjugation process is defective, then conjugated as well as unconjugated bilirubin will be high. If this excretory pathway is defective, then mainly the fraction will be conjugated bilirubin. So fractionation of bilirubin is very, very important to assess the different conditions. Now look at the conditions where we will have unconjugated serum bilirubin high. Either the hemolysis is there. How we can confirm it? We get a hepatoglobulin, we get retic count, and we get increased LDH. While looking at these 3 additional parameters, we can say this unconjugated bilirubin is because of hemolysis. Some genetic disorders are there, like Gilbert Syndrome or Crigler-Najjar syndrome, in which there is the enzyme deficiency, which has some problem in conjugation. So the indirect or unconjugated serum bilirubin will be high. A word about Gilbert syndrome. Gilbert syndrome is a very common condition. It is seen in 3 to 5% of population. The patients are almost asymptomatic. There is mild increase in serum bilirubin, which is generally never more than 6 mg%. And very important point, this is precipitated by fasting or any physiological stress. Like the patient is a normal patient who says that I have my dark eyes since birth only, and these dark eyes increases if I get some fever, if I get a surgery done, or any stress in the body which increases the serum bilirubin level. But the important point here to see is that this fraction will be indirect bilirubin, not direct bilirubin. Then comes the conjugated serum bilirubin, where all we can have, this is in either in biliary pathology or in hepatocellular diseases and certain genetic disorders of like Dubin-Johnson syndrome and Rotor syndrome, in which conjugated bilirubin, serum bilirubin is high. A word about raised bilirubin in newborns. Sometimes this report is interpreted by pathologists. The raised bilirubin, which is very harmful to newborn, the level, the neurological dysfunction can occur when it crosses, this level crosses more than 20 mg%. This fraction is directly toxic to neurons of basal ganglion and brainstem, and it causes sleepiness, hypotonia, seizures, and even death in the newborn. The Carnitas is a syndrome of permanent neurological sequelae in the survivors of this group. Lastly, I will just interpret the liver function test. What are the patterns of liver function test which we get? Look at the hepatocellular. Whenever we have disproportionate increase in AST or ALT as compared to alkaline phosphatase. That means only enzymes are raised, no increase in as compared to alkaline phosphatase. The second pattern is a cholestatic pattern when we have disproportionate increase in alkaline phosphatase as compared to enzymes. Mixed pattern when we have both alkaline phosphatase as well as enzymes, both are raised. Then comes the infiltrative pattern. We can have diseases in liver like sarcoidosis, amyloidosis, and other malignant infiltration of the liver, in which we have raised alkaline phosphatase in gamma GT with or without increase in bilirubin or transaminases. Lastly, we have isolated hyperbilirubinemia, which is a in which only bilirubin fraction is increased without increase in ALT, AST. R ratio is an important parameter. Nowadays, we calculate in every patient, in which ALT is measured, which is divided by ALT upper limit of normal. Say the ALT is 1000 and upper limit we make it 40. So this ALT is, this ratio will be 25. And if this is divided by ALP divided by upper limit of ALP, say ALP is 500. So the ratio will be, the normal upper limit is 250. So this will be 2. So the total will be 25 divided by 2. That is, the ratio is more than 12.5. So this ratio suggests that the patient has mainly hepatobiliary injury because the enzymes are very high. In the similar way, if this ratio is less than 2, this shows this is cholestatic injury. This table again shows almost the same thing which I have already described. Just look at the individual test. Hepatocellular injury, raised transaminases disproportionately, normal or mildly raised alkaline phosphatase, normal to mildly raised bilirubin, normal to low albumin, normal to raised INR. So this ratio of AST, ALT more than 2 shows alcoholic liver disease. AST, ALT ratio more than 5 suggests this is rhabdomyolysis. AST on ALT if more than 1000, I have already described in the past, suggest either this is viral injury or ischemic injury or DILI or Budd-Chiari syndrome. The second is cholestatic pattern. Again, in this, we have raised alkaline phosphatase of gamma GT. If both are raised, we suspect either choledocholithesis, cholangitis, some pancreatic mass, cholangiocarcinoma, primary biliary cirrhosis, or PSC. This needs further confirmation by doing ultrasound, CT, MRCP, or US. We can further delineate one of them. And if there is increased alkaline phosphatase with normal GGT, this shows this is a bone disease. This requires either bone scan or malignancy workup, TSH, calcium, or phosphate. Thirdly is isolated hyperbilirubinemia. I have already described either this is hemolysis, Gilbert syndrome, or Crigler-Najjar. If this is conjugated hyperbil, this is either liver or biliary disease, which can be assessed by doing ultrasound, or Roters or Dubin-Johnson, which are the genetic disorders. What are the parameters which we see in cirrhosis? Cirrhosis is basically end stage of any chronic hepatocellular or cholestatic injury in which irreversible fibrosis occurs in the liver. We must review for the medication history. What are the drugs the patient is taking, any history of alcohol, viral etiology as a cause for this, autoimmune liver diseases, Wilson's disease, workup for hemochromatosis or alpha-1 antitrypsin deficiency. And in case of cirrhosis, must look for CT abdomen to rule out any hepatocellular carcinoma. So thank you.
We will start with diagnostic approach to anemia. And I will deliver this talk, diagnostic approach to anemia. I can only say one thing, this teaching is a passion for me. I generally look for the opportunities where I can speak something and I can share my knowledge. So now I will share screen and start with my presentation. Now I think all of you will agree with me. This CBC is the most frequently asked investigation in any laboratory. And anemia is a very common presentation all across the globe. What is required? A good understanding how to approach a case of anemia is very important, because correct interpretation of CBC and correct approach to anemia, what all investigation shall be planned, is very important if we want to make correct diagnosis and we want to provide correct treatment to the patient. And simplest definition, sometimes we say anemia means low hemoglobin or low hematocrit or low RBC. Simplest definition is insufficient red cell mass to deliver adequate oxygen to peripheral tissues. And this anemia is not always a primary hematological problem. Sometimes it is because of some systematic disease, maybe hypothyroidism, maybe some connective tissue disorder, or maybe because of therapeutic intervention, some surgical procedure, or some other invasive procedure, or related to drug, some inflammatory agents, they are causing gastric bleeding and anemia is occurring because of that. So we have to keep all these things in mind in addition to primary hematological examination. And this anemia affects 24.8% of the world population. And in India, this is a major public health problem. 70% children between age 70% children, they are suffering from this anemia. 55% females in their reproductive age group, 21% male in their reproductive age group, they are suffering from anemia. And in India, in addition to iron deficiency, anemia of chronic disease is also very common. And most of the time, they coexist. The correct diagnosis is very important so that we can start correct treatment. So what is the first step? After a careful clinical and drug history. We know drug history is also very important. What is required? A thorough clinical examination, general physical examination, as well as systematic examination. And in clinical history, you have to ask for history of bleeding. Is there any history of hematemesis, hemoptysis, melena, some gynecological cause of bleeding, or maybe severe epistaxis? And many other things are important when we are examining patient. We have to systematically examine every part. After that, relevant laboratory investigation. And in this relevant laboratory investigation, what is the first thing we do? Complete blood count with reticulocyte count and detailed peripheral smear examination. Complete blood count, which is including your basic parameter like hemoglobin, hematocrit, RBC count, MCV, MCH, MCHC, platelet count, TLC, DLC, and RDW, and also include reticulocyte count. When we classify anemia, there are many ways of classifying anemia. They have some purpose. Some classification tell you what is the basic defect. Some classifications, they tell how to approach cause of anemia. See, based on etiology, it may be either hyperproliferative or some maturation disorder or hemorrhage or hemolysis. In hyperproliferative, there may be marrow damage, iron deficiency, or decreased stimulation of the bone marrow, a renal disease or inflammation or metabolic diseases. Maturation disorder may be cytoplasmic or nuclear maturation. And in case of marrow cause, in hyperproliferative, here I would like to stress on one thing. If the marrow is hypoplastic, don't jump to the conclusion it is because of some drug is causing bone marrow suppression, or it is hypoplastic anemia or going towards aplastic anemia. You must rule out the possibility of leukemia. Hypoplastic marrow is a known thing in case of acute myeloblastic leukemia, but in the last few years, after the development of many diagnostic modalities, hyperproliferative marrow is also observed in certain type of acute lymphoblastic leukemia also. Maturation disorder may be cytoplasmic, like thalassemia, iron deficiency, sideroblastic anemia, or nuclear maturation defect, B12 deficiency or folate deficiency, and maybe refractive anemia. It may be because of hemorrhage or hemolysis. In this, bone marrow is responsive because there is no defect in the bone marrow. In hemolytic anemia, there is peripheral destruction of the cells, and maybe because of blood loss. When it is hemolysis, so we have to see whether it is extravascular cause of hemolysis or intravascular cause of hemolysis. For this, we will conduct separate lecture where we will deal only with hemolytic process. Another thing is mechanism, decreased production or increased destruction or blood loss. This is another way of classifying this cause of anemia. In decreased production, reticulocyte count is decreased, and in case of increased destruction or blood loss, reticulocyte count is increased. So therefore, you can understand how important is this reticulocyte count. If it is decreased, then our diagnosis is limited to one set of causes. If it is increased, then it is sending us toward another set of causes. If you see the pathogenesis from proerythroblast to reticulocyte count, reticulocyte and ultimately RBC, in case of aplastic anemia, maturation stops at the level of blast. Blasts are not produced. In case of leukemia, blast cells are produced, but there is no further maturation. In case of megaloblastic anemia, B12 or folate deficiency, there is defect in the nuclear maturation, and in case of iron deficiency, there is defect in the cytoplasmic maturation. So now we can see, and in case of hemolytic anemia, there is peripheral destruction of the erythrocytes. And when we approach to a case of anemia, after examination of CBC, we interpret the findings. We see whether the MCV is less than 80 or more than 100. Normal MCV is 80 to 96 femtometer. If it is less than 80, it is pointing towards microcytic hypochromic anemia. And it may be because of iron deficiency anemia or thalassemia or anemia of chronic disease or sideroblastic anemia. If MCV is high, that means macrocytic anemia. In peripheral smear also we will find macrocytes. There is defect in the B12 or folate deficiency. And normochromic normocytic anemia, generally we see secondary to systemic diseases, anemia of renal disease or hypothyroidism. When we see this erythropoiesis in the maturation, these cells start losing their nucleus at the level of reticulocyte. In this reticulocyte, there is no nucleus, but RNA is there. And this maturation takes about 4 days, and in this 4 days, this RNA content start decreasing. If RNA content is very high, that means these are early type of reticulocytes. If it is only few bluish dots. That means it is late type of reticulocytes, and they enter circulation. They remain in the circulation for 24 hours, and when these are matured into red cells, then they lose their RNA content. And in this peripheral smear, these are observed as polychromatophores. These reticulocytes are observed as, and we are discussing this in little detail because this reticulocyte is an important investigation. You can perform this investigation in any laboratory, even if you don't have automation, or although there are certain limitations, but still you can perform. In this reticulocyte, ribosomes, these are stained with basic dyes, supravital stains, either brilliant crescent blue or new methylene blue. They form ribonucleoprotein complex, which is bluish or purplish in color. These are observed as granules within the red cells. Advantage is this is a cheap reagent, but this is non-precise method. Variation is very high, and long method, there will be some variation also. It is very difficult to decide. Another thing is fluorescent microscopy. We use acridine orange and fluorescent microscope, but they show false positivity with Hubble-Jolly bodies, Haynes bodies, Pappenheimer bodies, and also with malaria, babesia, in some cases porphyria. This is a precise method, but because of false positivity and some manipulation, this also has certain limitations. Then fluoroflow cytometry, fluorescent staining and flow cytometry. This thiazole orange specifically binds to nucleic acid. It is recommended by CRSI. But problem is, this is manual preparation and long method. It also has certain limitations. Another thing is, which most of the machines these days providing to us, automated reticulocyte count. In this, there is fluorescent staining, flow cytometry, and impedance. Flow cytometry tells us about cytoplasmic content, and impedance tells us about cell volume, or you can say cell size. Both has certain advantages. In this, again, we are using thiazole orange, which is bind to nucleic acid. Incubation time is very less, and degree of the fluorescence emission is directly proportional to amount of RNA in the reticulocyte. That means if you are getting high fluorescence, that means these are early type of reticulocytes. If you are getting low fluorescence, these are late type of reticulocytes. This is precise, rapid method. You can see in this reticulocyte maturation also, and some additional parameters. We will come to that. And there is no user manipulation. So in this automated reticulocyte, there is flow cytometry, impedance method, and they tell us about RNA content. If they are showing very high fluorescence, these are early form of reticulocytes, then medium type, low type, and mature erythrocytes. So where exactly you are getting the shadow, with that you can decide, and in this retic preparation, you get these type of cells. So you can correlate with this retic preparation, and with time you will get experience and you will be able to relate in a better way. And this automated reticulocyte provide very good information. If suppose it is more than 1,50,000, that means bone marrow is responsive. If it is less than 1 lakh, that means bone marrow is not responding in a proper manner. Either regenerative manner, anemia, if it is retic is more, and non-regenerative if the retic is low. And when we were discussing, In case of decreased production, it is non-regenerative, and if there is blood loss or peripheral destruction, bone marrow is normal, so it will produce high retic count and it is regenerative anemia. This classification, differentiation on the basis of this regenerative and non-regenerative, and if you are going by the percentage, more than 2% or less than 2%, this classification is given in the latest edition of Harrison's textbook of internal medicine. So retic is high, that means either there is bleeding or it is after some hemolysis or it is response to therapy. If retic is decreased, it is either nutrition deficiency or maybe after radiation therapy, bone marrow is suppressed, or a regenerative syndrome, there is decrease in the erythropoietin in chronic renal failure, or it may be because of some hypoplastic or aplastic anemia. Why we are discussing this reticulocyte count in detail? Because these things are not given exactly in a detailed manner, in a simple manner. In most of our textbooks, we have to accumulate from the different books. And what we generally follow, reticulocyte count percentage. How many, if we are counting 100 RBCs, how many cells are showing in a preparation? These reticulocytes. But it has some limitation. It has to be corrected for anemia. And how it is corrected? Reticulocyte percentage in multiplied by patient hematocrit divided by normal hematocrit. In adult population, generally we keep 45 as normal hematocrit. Otherwise, we have to follow, according to age, what is the normal hematocrit in a particular age. So we calculate this corrected reticulocyte count and we use this if we are following manual method. This is what I told you. Corrected reticulocyte count less than 2%, some bone marrow abnormality. If it is more than 2%, it is either blood loss or peripheral destruction like in hemolytic anemia. Then there is a parameter which is provided to us as we were discussing. These days machines are providing some new parameters also. Reticulocyte hemoglobin concentration content. Normal value is 28.9 to 33.9. You will find some variation in the values in different instruments. If this RHCC is high, it may be because of B12 or folate deficiency. But if this RHCC is low, it is very strong predictor of iron deficiency anemia. And this RHCC plays a significant role if you want to differentiate between iron deficiency anemia and anemia of chronic disease. Because in case of anemia of chronic disease, your ferritin is not low, your iron is low, but TIBC is also low. These all parameters are disturbed. In these cases, suppose a patient of rheumatoid arthritis develops iron deficiency anemia. Now it is showing features of iron deficiency anemia as well as anemia of chronic disease. And these ferritin, iron, TIBC will not help you. Even percentage saturation will not help you. Here it plays a role. If this RHCC is low, it is suggestive of iron deficiency anemia. And if high content reticulocytes are present, and if you are able to observe this, suppose some patient has received bone marrow transplantation, or after chemotherapy the patient is recovering, or after radiotherapy the patient is recovering. If this high content reticulocyte you are able to see, that means bone marrow has started responding, and this will show you recovery. This will increase after before there is actual increase in the absolute reticulocyte count. So this is very important. That RSCC is very important. Even this erect H is very important because these are helping us in reaching the diagnosis. And if you see iron deficiency, what happens in this? There is decrease in the iron, increase in the TIBC, decrease in the ferritin. If you will take the history, there is either history of bleeding or stool for occult blood is positive, or some parasites are there in stool, or there is dietary insufficiency. Clinical assessment of blood loss is very important. And endoscopic evaluation of GIT is very important in case of iron deficiency. If there is microcytic hypochromic anemia, reticulocyte count is low, ferritin is low, don't jump to the conclusion, particularly in an aged patient, that there is a dietary cause, there is nutritional deficiency, this is iron deficiency anemia, you are starting iron. Go for endoscopic evaluation. First stool for occult blood and then endoscopic evaluation. Even if stool for occult blood is negative, you must send the patient for colonoscopy. If you are not finding cause in the lower GI, go for upper GI endoscopy, because we have observed many cases of bleeding malignant ulcers which were diagnosed in the endoscopic evaluations, and they were bleeding intermittently. So one particular time you were not finding stool for occult blood positive. This is very important. Then observe red cell parameter very carefully, because these are providing only mean value, these machines. If suppose there are microcytes as well as macrocytes, MCV will be normal. They will not reveal variation in the population of red cells. So you have to observe perfuse smear to see the variation in RBC size and shape. In iron deficiency, you will find more anisocytosis. Red cells of variable size, there will be more anisocytosis, variation in the size. In case of thalassemia, there will be anisocytosis as well as poikilocytosis. And you will also find significant number of polychromatophils. This you can also observe a patient on treatment. In case of folic acid, you will find hypersegmented neutrophils, macrocytes, macrovellocytes, and these hypersegmented neutrophil you call when these nuclear lobes are more than 5% cells are showing more than 5 lobes, or 1% showing 6 lobes. So this count is called Arnath count. All of you know, but just for the revision, I am telling you. Dual cell population we find in sideroblastic anemia or a iron deficiency anemia on treatment. Sometimes we find nucleated RBCs as well as leukocytes in the blood, immature leukocytes and nucleated RBCs in the peripheral blood. This is called Leukoerethoblastic Infiltrate. And where we observe this? In hematological conditions as well as other malignant conditions. In this, bone marrow microenvironment is disturbed. And rouleau formation, all of you know, this we see in multiple myeloma. And agglutination we find in cold agglutinin disease. And in this rouleau formation, remember one thing, if all these rouleaux are in one direction, it may be some slight preparation artifact. In multiple myeloma, we get a rouleau in different directions. Bone marrow plays very important role. And see, here we are just reviewing the approach to anemia. We have kept separate lectures, one in approach to hemolytic anemia, one is approach to pancytopenia, one is approach to triad of anemia, jaundice and splenomegaly also. So that time we will discuss all these things in more detail, and also we will discuss molecular diagnostic in hematology, and all these things are in planning. Bone marrow examination is required. If we are suspecting hypoplasia in the bone marrow or marrow infiltration or myelofibrosis. And remember one thing, generally we perform first bone marrow aspiration, then biopsy. But if there are certain clues, if reticulocyte count is very low, or we are finding teardrop cells and huge splenomegaly also, we are suspecting myelofibrosis, you will not get anything in the bone marrow aspiration, then we can go for aspiration, biopsy both. And these days, otherwise also, what is the latest recommendation? You go for aspiration and biopsy, both. In sideroblastic anemia, you find ring sideroblast. When you stain bone marrow slides with pulse stain, iron for iron. Megaloblastic anemia. See, we perform bone marrow aspiration or biopsy in megaloblastic anemia, not only to diagnose B12 or folate deficiency, that we can diagnose with serum levels also. We want to rule out any occult hematological malignancy because these may produce megaloblastic anemia because of folate deficiency, which is occurring as a result of rapid cell turnover. So this we have to keep in mind, or ineffective erythropoiesis or storage disease like Gaucher disease, etc. Bone marrow examination helps us. And when we say it is pancytopenia, hemoglobin or RBC, these are reduced, TLC is reduced, and platelet count is reduced. And the very common cause is anemic patient. Anemia is very common in our country. If suppose that patient develop viral fever or enteric fever, or particularly this, although the dengue is also viral fever, but dengue fever. Anemic patient developing this type of illness, this can cause pancytopenia. We have to keep these things in mind before we are going for bone marrow examination. Megaloblastic anemia. In fact, in India, most common cause of pancytopenia is megaloblastic anemia. Aplastic anemia and paroxysmal nocturnal hemoglobinuria. This is the only hemolytic anemia which can cause pancytopenia. Leukemia or bone marrow infiltration by some malignant process. Now, we have discussed briefly this approach to anemia. Now we will see when we are interpreting this CBC, what we have to keep in mind. See, this 35-year-old female, there was some difficulty in the sampling, veins were not clear, and they collected 1 ml blood in 2 ml EDTA tube. And these were the findings. Now, what happened? After this, they thought hemoglobin is normal and MCV is low. Probably this is some hemoglobinopathy. They went for this iron studies. It was normal, so they thought this is some hemoglobinopathy, and they were planning for HPLC. But somehow they got the idea that first we should repeat this CBC, and repeat CBC was normal. What is the problem here? Hemoglobin is 13.5 and hematocrit is 33.1. The ratio of 1:3 is not maintained. Why? Because MCV is low and hemoglobin is normal. There is something which is disturbing our MCV. See, in 2 ml EDTA tube, we are collecting 1 ml blood. This excess EDTA is causing shrinkage of red cells and low MCV. So therefore, hematocrit is a calculated parameter in our analyzers. So because MCV was low, we got low hematocrit. So this was alarming. This ratio was not maintained. And when they collected carefully sample second time, so they got MCV normal. So we have to keep in mind, we are analyzing this and we are also examining samples also. In 2 ml EDTA tube, they are collecting proper volume. It is not overfilled or underfilled. Overfilled may cause some small clots and underfilled may create this type of problem. Another patient came for routine checkup and with good health, but hemoglobin is low, TLC is low, Platelets are also low. MCV is normal. They thought this is a case of pancytopenia. We should go for bone marrow. But a technician noted a clot. This clot was responsible. Maybe tube was overfilled or they didn't mix the sample properly. So these things are also important when we are interpreting our hematology. Now see, in this, hemoglobin is very high, TLC is very high, MCV is normal. They thought this is some myeloproliferative disorder. And they were planning for bone marrow. But what was the reason? In this case, serum was lipemic. And lipemia was causing pseudoleukocytosis and pseudo increase in the hemoglobin. That is why I am saying these pre-examination requirements are very important. Because in this present day, with lot of technological improvement, our analytical errors are few. But this pre-examination, post-examination errors, they are constituting about 80 to 85% errors. And out of these two, most of the errors are because of pre-examination. We have to be very careful. This patient was receiving IV fluids, hemoglobin low, TLC low, platelet also lower side. What was the reason? Sample was collected from the arm where the patient was receiving IV fluids. This is also very important. We have to keep this in mind. It is not only hematology which we are reading in Wintrow or William, for that matter, or any other reference, maybe Harrison. This is our day-to-day practice. We have to keep all these things in mind. 30-year-old female with anemia. In this, hemoglobin 6.6, MCV 88. They thought this is normocytic normochromic anemia. And they ruled out nutrition anemia based on this MCV. But we just discussed, it is not telling us variation in the red cell population. When this peripheral smear was examined carefully, then there were macrocytes as well as microcytes. It was nutrition anemia, which was ruled out on the basis of normal MCV. One female with fatigue, hemoglobin low, TLC lower side of normal, platelet slightly low. In this, reticulocyte count is 0.8%. And the normal reticulocyte in percentage, generally we take 0.5 to 2%. They thought this is normal reticulocyte and probably some hemolysis or we have to look for bleeding. But when this reticulocyte was corrected for anemia, then they realized this reticulocyte is low. We have to find out what is the cause of low reticulocyte. Bone marrow is not responding. This careful evaluation is very important. Or see this. American female, fatigue, bilateral hip pain, facial rash. In this, reticulated hemoglobin was 28.8, reticulocyte 1%, MCV low. They thought this is microcytic hypochromic anemia, but in this case, ferritin was normal, 15 to 300 is normal value. CRP is high, ESR is high, ANA is positive. So they thought this is some connective tissue disorder because ferritin is normal. HBS, sickle cell trait was also there. But in this case, RHCC was low, slightly low, but it was low. It was pointing towards iron deficiency anemia. When this patient received iron, there was improvement in the hemoglobin. So now the conclusion is, for the diagnosis of anemia, careful evaluation of CBC parameters is very important, and include reticulocyte in your routine CBC. Don't wait for the clinician to ask for it. Include this. reticulocyte in your routine CBC as other parameters, and also learn the importance of newer parameters which your machine is providing. We will have separate lectures, one lecture, what is the interpretation of these newer parameters which our machine is providing, because they also play a significant role in the evaluation of the cause of anemia. And always remember, this will help you a lot in many cases. If you are examining bone marrow, you are dealing with hematology cases. Whenever you are dealing with case of iron deficiency anemia in an aged patient with well-maintained nutrition, rule out GI malignancy. Go for lower GI endoscopy. If that is normal, go for upper GI endoscopy. If it is megaloblastic anemia, don't jump to the conclusion. Again, in middle-aged patient with adequate nutrition, this is B12 or folate deficiency pure. Rule out hematopoietic malignancy. And if suppose you are getting frank picture of megaloblastic anemia, provide B12 and folate, wait for some time, keep patient under close observation, perform bone marrow again, then a occult malignancy may become overt. Here the role of pathologists come in the picture, right? Thank you very much for your patience.